last 5, 6, 7 years. And what it is now, it's really a reflection of how we treat a whole person with multiple injuries and multiple problems. But the focus of this lecture today is really going to be to introduce you to this model we've called the integrated systems model, with a focus on recurrent hamstring pain and injury. So I'm going to take you through the model a little bit. There's a lot of players, pictures of the players that I took from your website, from the Whitecaps website. And if some of them are not there anymore, or you don't want those pictures in the presentation, just tell me, put a big X through it, and I can certainly substitute them. I'm recording this at the moment for you guys so that you guys can have it in your library and come back, and I'll put this together so that you can see it again and again. So I know you're probably not frantic note takers anyway, but don't worry about having to capture all of this. Let's just go for the next 2 hours and have some fun and play with a few simple tests I want to show you, some screening tests I want to show you that pertains to this model. So you all know that a functional pelvis is essential for almost every task, including, do we call it soccer here or football? Call it soccer? Football? Like. Soccer? Whatever we like? Okay. For the sport that you're involved in, for soccer, for football. Years ago, I used to travel and teach with Dr. Andre Vleming, who is the chairman of the World Congress on Low Back and Pelvic Pain. He heralds from Europe. And Andre used to say, and still does say, that the pelvis functions like a platform to which attaches 3 levers, the legs of which are 2, the trunk is the 3rd, and that the platform has to be stable for optimal function. So if you think of the pelvis much like a dining room table with a leaf in it, if the leaf is giving way every time you land on the leg and there's a small buckle within the pelvis, you'll only be as strong or as agile or as fast as your weakest link. So if the pelvis gives way first, then other things will start to compensate for it. And so as we were traveling and teaching together, we came up with a different model, not the integrated systems model, but this integrated model of function. And it's an evidence-based model in that it is derived from both clinical experience, which was predominantly mine, and from the science, which comes from a collaboration of all these people you see on the slide. A number of people's work sort of been integrated into this model. And it has 4 parts. The first part considers form closure, which is the role of the bones, the joints, and the ligaments. So obviously the sacrum or the innominate can't be fractured in order to stand on your leg. The ligaments have to be intact, and the joint has to be fairly healthy. And that's not often a problem that we see in sport. More often what we do see is a problem with the force closure mechanism, the extra forces that are required to hold a joint in the right position at the right time. So this includes the integrity of the myofascial system. So things like sports hernias in the abdominal wall, things like problems with if a player has had surgery, any surgical intervention in the area, whether it's in the leg or in the back or in the groin, all sort of leave a shadow of their effect in terms of their performance. And then more recently, particularly starting in around the mid-90s, was the role of neural patterning, motor control as it's often called, the sequencing and timing of different muscles. And this plays a huge, huge part in chronic persistent pain anywhere in the body, where the brain gets rewired to be using different brain maps, different orders, different sequences of timing of muscle. And it's not new. The evidence certainly started in the mid-90s, but prior to this, Vladimir Janda and Shirley Sarman and several people years before that in the 70s were noticing that in people with chronic pain, they often had disordered sequencing of muscle firing patterns. And this is about the brain, where the brain and the nervous system that's embodied through the entire body. So according to Dan Siegel, the brain is embodied throughout. It doesn't just live in the skull. So we have the distributed nervous system throughout the whole of the body is sending information to the brain and telling the brain which muscles to use when. This has become a huge, huge part of training now, that we train the brain first to perform in a certain way, and then we can build those patterns with strength and conditioning. Because you cannot strengthen a muscle that your brain isn't using. So if you have a multifidus deficit and you've got loss of control of the back of your pelvis, and multifidus, as we know from Julie Hyde's work, if it becomes inhibited after a back injury and its recovery is not spontaneous, it doesn't come back automatically. So that's like not having air in your balloon for your sacrum, because what multifidus does is it puffs up the fascia, tightens the fascia at the back, and it's like your compressor belt at the back. It gives you this support at the back. So if it's not working, you now have got a collapsing dining room table, okay? And so you can't, if And it doesn't just come back by doing clamshells. Clamshells are often given to strengthen up the posterior gluteal group, and when your multifid isn't working well, your glute tests will all test positive. But all of our muscle tests are really about testing slings of muscles and not just one muscle. So if any muscle within that sling is not firing properly, the test will show up weak. All right? So we've got a couple of tests, or one test later that we're going to play with that will really highlight this myth that we can actually test one muscle. But we need to train the brain first to remember how to use a specific muscle in a specific order, and then we can move it into strength and conditioning, okay? And then finally, there's the whole impact of the emotional state, fear avoidance. If you've had a significant injury and you're off from play for a while, the whole psychological aspect of being able to trust the leg, feeling that you're going to take a hit, and it's not going to happen again, that whole thing, what it does to the whole motor control system. So this model that Andre and I put together in 1998, the integrated model of function, was really one specifically as it pertained to the pelvis. It wasn't a whole body model. It is a model about restoring form and function for the pelvis. And we know that a functional pelvis is essential for every task. And most of the research that's been done on it, for both classification of pelvic disorders, have focused with subjects with low back or pelvic girdle pain. That's how the studies all start. We took a group of people with low back or pelvic girdle pain, and we looked at this, or we did this, or we did that. So it always starts with pain, right? So how common is it? Well, it's difficult to determine pelvic girdle pain strictly from the literature, because often the studies combine both together. And that's like, if we bring it to the lower extremity, saying we took a group of people with knee and ankle pain and saw how common it was. Because L5-S1 or L4-5 is part of your low back, and it behaves very differently than the sacroiliac joint. But because they're so close together, it's often framed as lumbopelvic pain. But what you do for control at L5-S1 is totally different than what you do for control of the sacroiliac joint. So Andre Fleming got a group together as part of the European guidelines and did big systematic reviews of all of the studies to look at some of what is the best evidence we have on this topic at the time. It was published in 2005. And in the non-pregnant groups, which is obviously the groups that you're working with, because I've yet to see a soccer player get pregnant, it's not on a male team anyway, there really are no good studies that have looked at how common is pelvic girdle pain, right? The best systematic review was done by Wu et al. In 2004, and there's a lot of methodological problems in these studies, so we don't know. We don't know how common it is. Whereas tons of research has been done in pregnancy-related pelvic girdle pain, most of it from Scandinavia. So I can tell you lots about what pregnant and postpartum women's problems are, at least Scandinavian ones, but that's not the purpose of our lecture today. Recovery of function postpartum, we also know that if you're worried about your wives, only 5 to 7% of women fail to get better after pregnancy. Most of them do really, really well. So even though it's common in pregnancy, 1 out of 5 women will have low back or pelvic girdle pain. Most of them do get better. But we don't know in terms of the non-pregnant groups. The data's just not there. Minimal research, however, has been done on the subjects we're interested in, and that is those with a non-functional pelvis that contribute to pain or chronic injuries or sudden injury elsewhere in the body. So when the pelvis isn't hurting, but it's just not functioning well, what are the compensations? What tends to adapt? What tends to happen to predispose or to set this player up for risk? Can we screen them at the beginning of the season, halfway through, every 6 weeks? Can we do these 4 little tests quickly, screen through and go, okay, you're starting to get into trouble. That hit that gave you that little bit of back pain for 48 hours has rewired your brain map. It's changed this. The muscles aren't working well. You're predisposed for the next time you go to kick that ball hard and twist to tearing your hamstring. And there's no data to support that. But if you use these 4 little tests I'm going to show you, I think you'll be able to predict and pull them out, and you'll be able to just give them 1 or 2 sessions of rehab, and they don't have to miss any games, and they'll be right back in. So you'll be on top of things that are changing before problems arise. And this is what Man City did, and I'll tell you a little bit about their training and what we've done for them over the last 3-4 years, okay? So when you have a non-functional pelvis that's contributing to injury or pain elsewhere, how do we know? How do we pick those up? Similarly, and this is obviously a woman, she's wearing a bra, but look at this thorax. It's not moving very well, right? She was a golfer. you can imagine how good a golfer she was. Not very. Because if you can't rotate your thorax, you're not going to be a very good football player, right? So when you have impairments elsewhere that are contributing to the loss of pelvic control and pain, no one studied this either. So we don't have many studies that have looked at ascending and descending influences on the pelvis. And therefore we have to rely on our clinical experience, which fortunately we have a lot, okay? So when your pelvis gives way, it's tough to play anything, right? It's tough to sit, it's tough to stand, it's tough to walk, it's tough to do pretty much anything. And so we have a lot of questions that are not yet answered by the research. When the pelvis gives way, does it produce pelvic rhythm? Clinically, my answer would be no. You'll see an awful lot of people who have giving way or their pelvis letting go, but it doesn't have to hurt, right? It doesn't have to hurt. Well, if it doesn't have to hurt, what other conditions can it contribute to? What other conditions are in part due to failure to transfer loads effectively through the pelvis? Can we agree on how to reliably determine when the pelvis is giving way? This is a huge point in science. You can't use any test in a research project which doesn't have inter-tester, intra-tester, reliability, sensitivity, and specificity. And we're not there yet in most of the joints in the body. Okay? So do we agree on how to determine that it's giving way? No, we don't, but we have some science that I'm going to tell you about that I think we should be using. And what does giving way mean anyway? What system does it really implicate? And is the pelvis always the criminal or the cause? And at this moment we call it the primary driver, the thing that's driving the domino effect throughout the body? Or can the pelvis be a victim of an impairment elsewhere? Can you have an old ankle sprain which has stopped your subtalar joint from moving properly, that tends to make the leg internally rotate as the foot pronates with every step? And is that ascending internal rotation force exceeding the ability of the glutes and the multifidus to hold this together? Do you then have to hang on with the hamstring? Does that then set you up with an overuse injury of the hamstring that then tears or goes, or a groin, or a labral tear, or an FAI, or anything sort of in this area? The driver for that may be that unless you get the subtalar joint functioning properly so they can plant and twist and absorb some of the rotation, the movement in the foot, you're never going to offload this. But similarly, if you've got a control problem in the pelvis, where there's neuromuscular deficits here, where your abdominal mechanism and multifidus aren't synergized with your glutes and the whole system's not stabilizing at the right time, as you stand on the leg, if there's a very small buckle or giving way in the pelvis, that will create a descending internal rotation effect, cause the foot to pronate, lose the spring, and how well you can jump up to head that ball is then going to be compromised. That's a pelvic-driven foot fault versus the other one, which was a foot-driven pelvic fault. One needs attention to the foot, the other needs attention to the pelvis. A very simple way to know, do I go for the foot, do I go for the pelvis, do I go for the thorax, do I go for the guy's cranium, where the tentorium cerebelli has just been so twisted because he always hits the ball on the right side of his head. So if you hit the ball on the right side of your head all the time, and at the same time you have your neck turned like this, and if at that moment sternocleidomastoid decides to go into spasm, it posteriorly rotates the temporal bone, shifts your sphenoid. You have a rotated sphenoid. You have a rotated sphenoid. In fact, most of you do. You don't. You don't. Okay? You have a really rotated sphenoid. Stands in front of the How do I know? I forgot your name already. John. Hi, John. Look at John's eyes. They're gorgeous. But look at John's eyes. Can you see one set back deeper? Yeah? Come on. Sphenoid rotated to the left. Sphenoid rotated to the left. Perfectly balanced sphenoid. See how the eyes are level versus one that's back. Right? Yours is less than these guys, so I brought these guys out. The sphenoid rotation in the head is driven by what the occiput does, because the occiput attaches to the sphenoid. So when the occiput rotates, it rotates the sphenoid, draws the orbit back. And the simple mechanism for that is the rotation of the temporal bones, often pulled by sternocleidomastoid. How many times do you see guys, I won't do this because it'll really hurt my neck. How many times do you see guys hit the ball and then do that with their head? You're not supposed to, are you? At least I don't think you are. No, but they often do when you watch the videos, how to see guys things. So how do you know if you don't have a cranial driver? Because if the cranium is rotated like that, and you have this change in the cranium, it's going to create rotation spirals all the way down, all the way down through the thorax, which creates a change all the way down to the feet, okay? So the point of mentioning that is just that we can't just look at the hamstring anymore when we have posterior thigh pain. Because as soon as you know something about the whole body, you're beholden to actually use that knowledge, right? So when should we treat the pelvis and when should we treat elsewhere? When is the pelvis the victim and when is it not? So I'm going to tell you a little bit about the evidence, what's known about hamstring injuries and the most effective way to treat these conditions according to the evidence. We're going to talk about why the pelvis should be considered. And you'll note that there's not a whole lot of good research evidence about this as yet. And then we're going to get into two key features of the integrated systems model, which is a model that's co-developed between LJ and I, to help determine when you should go after the pelvis when you've got somebody with persistent posterior thigh pain and when not, and how you can very quickly determine if it is the primary driver. Do you have a hamstring-driven pelvic problem, a pelvic-driven hamstring problem, okay? We're going to practice 3 key tests to determine if the pelvis is playing a role in your athlete's posterior pain. I'm going to demonstrate one test on Rick. I'll use Rick because it's part of Linda Jody's thoracic ring approach. It takes a little bit of skill a lot of skill actually, in order to be able to pick up ring drivers. But I'm going to show you the principles of the model and how it relates to the hamstring. And then we're going to do one group practical test where you can actually screen the thorax. So you'll be able to, well, I'll introduce you to this approach so you can start to screen your players to pick up, all right, you've got a rib that's part of a ring that's not doing what it's supposed to do, and we've got to get you some tension, okay? And I'll show you some videos from the footage that your team sent me so that you can actually start to see when should I be paying attention to the thorax of this person with persistent thigh pain, okay? So as you know, hamstring injuries are the most common injuries in athletics involving sprinting. A lot of the studies have been done in Australia, and 20 to 35% of injuries across multiple sports are due to posterior thigh involvement. In your league, and this number comes from Rick, 37% of the injuries involve the hamstring, 28% of the groin and hip. Now in the Australian Football League, and Australian football is a little different than European football. This is the Aussie rules football, that crazy game that they play with minimal protection as well. Biceps femoris is most commonly involved, mainly at the proximal musculotendinous junction, in 80% according to these series of studies. Right? But you do still see medial hamstring tears. It's not always about the biceps. You do see them on both sides. And it's thought that the injury most likely occurs just before foot strike when you're sprinting. Now, in soccer or in football, I think you'll probably find that it would occur for this fellow who can't flex in his hip. You can see how his center of mass is posterior to his base of support here, where his thorax is way back over his foot because he's not flexing in his hip. Now, you got to remember, I've just captured these pictures from a moment in time. So whether he was coming back out of a good position, I don't know. But when he's in this position now, this is non-optimal, not only for his weight-bearing leg, but it's also non-optimal for this leg, right? There should be more flexion in his hip. But this is often when the injury occurs. It's either during high kicking or during sprinting. Now this is an interesting statistics, and everybody cites it in the sports world. This high rate of recurrence. So you have a player that injures the hamstring, they go through the protocol, whatever the rehab protocol is, they're pain-free, they're doing all their agility drills, they're doing all the things you want them to do, you send them back onto the pitch. And then what happens is that 30% of these injured players will recur, their pain or their limitation will recur on return to sport. And 12% of these are the first week back, which to me says they weren't completely rehabbed. There were still things going on that we weren't picking up, right? There's still things going on. Because we want this number to get low. This is what's happened for Man City, is that this doesn't happen anymore, right? They go back and they're back. Right? Now, Robin can tell me the data on that, but this has really, really changed for them, okay? Now, what are the risk factors according to the evidence? The risk factors are, if you have a past injury of posterior thigh pain, you're 5 times likely to have it happen again, which again suggests that we're not completely rehabilitating these players. Okay? If you've hurt your knee or your groin before, significant risk factor for hamstring. And again, it tells us that the rehab for the knee or the groin was insufficient. Those brain maps, the way you're using the muscles in your whole body, or you're using your whole body, still is not optimal for your lower extremity. Okay? A higher age. Well, this probably relates to probably most of the players that you're working with. If they're over 23, 4 times likely to injure, likely because the athlete has had multiple injuries through their teenage years. They don't arrive at this level without having had something happen to them in the past. Okay? Predictors for return to play, time to be able to walk after the injury. So if your player injures their hamstring and it takes them more than 24 hours to weight bear on the leg, it's going to take them longer than 3 weeks to return to play. And I don't know how useful that is clinically. I mean, I know you need to be able to predict, but I think there's probably better tests that we can develop and start to screen on a go-forward basis that tell us how long people are going to be off for. We just need to start tracking the data when we're looking at it a little bit differently. Okay? So the evidence to suggest we should consider the pelvis, well, it was Andre years ago in the 90s who published some data, some papers showing the continuity of muscles to ligaments through fascia. And that previously we used to consider muscles as having origins and insertions, and we don't anymore. Muscles are contained in fascial envelopes. They distribute their force through the fascia, and some of it goes through the tendons, but there's continuity through the system. And so the biceps femoris sends its force into the sacrotuberous ligament, which is a prime ligament that stabilizes the sacroiliac joint. It's a very strong ligament. And it's often at this high interface here between the lower part of the sacrotuberous ligament and the musculotendinous junction that tends to go. Because you've got a very compliant tissue that then meets a very non-compliant tissue, bone, and then a medium compliant tissue, namely a ligament. So we have anatomical continuity. For sure. Now, is there any evidence to support the hypothesis that motor control impairments of the pelvis can impact function of the hamstrings? We have one study, and it's only one study, but it is a fantastic study. And this is a study that was done by Barb Hungerford as part of her PhD at the University of Sydney. And the study was done on the University of Sydney track athletes. So the subjects were all between the age of 18 and 25, so fairly young, fairly active. They were runners, right? And that's what you do when you play soccer. You run a lot. And so what she did is she looked at the one-legged standing test. So just stand on one leg and then lift the other. They were standing on a force plate so that she could determine exactly when weight was shifted, when the toe was off the plate and they were onto one leg. And one of the studies they did is they measured with surface EMG the activation of timing in its relationship to weight shifting. So this point here, the 0 point, is when the toe on the opposite side came off the force plate. So at this moment in time, what was on, what was off. So when the toe was just off the force plate. So it wasn't a high hip flexion, it's just taking the load through the leg, okay? And she couldn't separate activation of internal oblique and transversus because it's with surface EMG. You need indwelling EMG to differentiate them. This is multifidus, biceps femoris, adductor longus, glute max, glute med, and TFL. Now, it would have been really nice if she'd been able to do semimembranosus and semitendinosus, but there's only so many electrodes and so much data, or so much committee electrodes in the machine that you could get. And I think on reflection, if they'd known what the findings were going to be, they might have looked at it. In the control group, in the healthy subjects, there was early activation of the abdominal wall and multifidus, which fits with the rest of the stability research, right? That you have anticipatory activation of the stability muscles first. But what I want you to pay attention to is the sequencing of timing of biceps here versus your glute max and med and your TFL. So your hip stabilizers here are all coming on before your biceps, right? In the normal healthy controls. But in the subjects that had pelvic girdle pain and difficulty standing on one leg, there was a delay in the activation of the core stabilizers, which is consistent with the research across the low back pain population. But this is the key piece for this study. Not much change in the adductors, not much change in glute med, not much change in TFL. So those probably wouldn't be statistically significant. The statistically significant finding is this: complete reversal in the activation of biceps femoris and glute max. So now your biceps is starting to become a servile muscle to try and stabilize the pelvis. And Andre figures that's because of its role through tightening the sacrotuberous ligament, that the brain starts to use it more. So now we got a biceps that is not only working to control the knee, but it's trying to control the SI joint. It's probably contracting concentrically when it should be relaxing, or at least contracting eccentrically. And this poor guy's doing it all until it gets to the point where it just can't do it anymore and it tears. Okay? So knowing how to pick up, well, is the glute max firing, or when is glute max firing, when is the biceps firing, would be a lovely, simple test that we could do. Okay? So this is our first test. We're going to look at the timing of glute max and biceps in one-legged standing, and we're going to do it like this. Okay, John, come on up for a sec. So, how many are we? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Perfect. Okay, find a partner. Come on up to standing, and Rick, we can probably switch the light on.
Okay.